So good evening, everyone. Uh, I welcome you all to the Mastery of Surgery session of IASO Academics. I now invite our IASO President, Dr. Subramanieshwar Rao sir, to start the session.
Good evening, everyone. Welcome to Mastery of Surgery on lung cancer. We have three speakers today. The first one is someone very special. Sagar Katiwada is a very renowned surgeon. Actually, he is into multiple organs from different organ systems in the body. A brilliant surgeon and an excellent speaker. I've been hearing about him for the past 2 years from colleagues, and we wanted him to enlighten the faculty and the residents of surgical oncology. Thank you very much, Sagar, for joining us from Nepal.
Thank you, sir. Thank you very much, and thank you, IASO.
And you would be talking to us about radiological anatomy of the bronchopulmonary segments.
Yes, sir.
Yeah. Vijayaraj Patil is an associate professor of surgical oncology. All of you know him. The Memorial Institute of Oncology is doing great work in Kidwai, and he's a very passionate teacher. He'll talk to us about surgical anatomy and approach to lobectomies of right lung. And then someone who's a household name in surgical oncology, Sarvan Raj Manikyam, surgical oncologist and director of Thangam Cancer Center, Namakkal. Be talking to us about surgical anatomy and approach to lobectomies of left lung. So for once, we are discussing right and left lung separately because they are truly different, especially in anatomy. So listen to them and enjoy yourself. Thank you.
So we will be starting with our first talk of Dr. Sagar Katiwada. We'll be playing the video from our end.
Namaste, I'm Dr. Sagar Katiwada. I'm going to deal about radiological anatomy of bronchopulmonary segments today. So I work in DP Koirala Memorial Cancer Hospital. This is the largest cancer hospital of our country. Basically, I am a GI surgeon, surgical gastroenterologist, but I practice pole surgery, pancreas, esophagus, lung and liver because I work in government institute and I was permanently recruited at thoracic oncosurgery department. So I am performing the surgery of pancreas, esophagus, lung and liver. I also do some surgical illustrations. You can see here some surgical illustrations I have drawn or illustrated liver, pancreas and its vasculobiliary system. Basically on today's presentation, I'll be showing my illustrations. So to clarify some of my illustrations, I have to give the example of this very particular thing. Here you can see the lung in anatomical position or resting position, where you can see the bronchus are towards the cardiac side, whereas this is superior division of upper lobe bronchus and inferior division of upper lobe bronchus. The inferior division will be faced towards cardiac side, whereas superior division will face towards apex and towards posterior side, right? So while we do surgery, you will not find this very orientation. You will see it while doing lingulectomy or while doing surgery. You have to reflect the long lobe towards other side. So the lingular bronchus will be on different position or different topography or different orientation. Again, Takahashi Nakamura has also shown some reflection-deflection technique in Clisonian pedicle transection of liver. Similarly, Tontar Tung in liver surgery for digging finger technique. Nomori described the Nakamura reflection view of lung for depiction of segment of lung. Similarly, Stephen Bain described about opening book model for critical view of colectomy. So, I'll also show some reflection and deflection methods. So the illustration may be little different from your real textbook. So this is the illustration drawn by myself. So you can see here main pulmonary trunk, and it is giving branches ascending A2 branch, and this is middle lobe. This is reflected towards other side. So in original textbook you may see this middle lobe artery towards cardiac side or towards this side, but while doing reflection or deflection of the middle lobe is retracted towards other side, so this artery will also be retracted. Basically, while doing the nomenclature of the bronchial segments and subsegments or arterial segments and subsegments, we should follow the Jackson-Hoover method. Edward Boyden, Hiroaki Nomori, as well as Liang Chen, who are very famous segmentectomy, who are very famous in doing segmentectomy, also follow the same rule. So now let's see here. The formula is SIPALM. For example, superior, inferior, posterior, anterior, lateral and medial, right? So if there is B6, let's say B6, segment 6 bronchus, B6 bronchus has 3 branches. One is superior branch, other is lateral branch, and other is medial branch. Whereas anterior, posterior and inferior branches are missing. So while doing nomenclature, you can see here superior bronchial division will get, this superior division will get the name B6A. It is very simple now. But inferior is missing, so B6B is for another one. Inferior misses. Now let's go to posterior. Posterior also misses. Let's go to anterior. Anterior is also missing, so B6B would be given to the lateral bronchus, and finally B6C would for medial lobe bronchus, medial subsegmental bronchus, right? In the same way, Ikeda also described if there is subsegmental bronchus, then we will be using Roman numerals like first, second, third, fourth, or if there is subsegmental bronchus, other further division, then there will be alpha, beta, gamma. In this way, nomenclature will be added on. So on the original textbook of Ikeda, they also follow the Jackson-Hoover system of nomenclature. So Jackson-Hoover system of nomenclature. In that edition, they have said that for subsegmental bronchi or fourth level division, the nomenclature will be given by Roman numeral first, second, third, fourth. Whereas for fifth order division, the nomenclature will be given by alpha, beta. On the page 61 of same author, you can see here a very surprising image. So what is here is that the superior division of upper lobe bronchus give rise to B1 plus 2 and B3. The B3 has 3 subdivisions. One is B3A, B3B and B3C. Based upon Jackson-Hoover nomenclature, we know that superior should have got the name A, but here the name is B3C. Is it mistake? No, it's not mistake, because before Boyden, there was establishment of only 2 subsegments of segment 3, that is lateral and medial. Lateral would get the name B3A, whereas medial would be getting the name B3B. So the nomenclature is correct. What is added is the new discovery of the segment, that is split bronchus segment, split anterior bronchus segment. So this anterior will split into B3. So superior and anterior, true anterior. So this splitted segment is present in, segmental bronchus is present in only 33% of the cases. So many of the cases it is missing. So lateral, medial and this new discovery, so it gets the name B3C instead of getting B3A. So this is my original illustration. You can see here the trachea and this carina. So on the right side, right main bronchus, it will give right superior bronchus. So it has 3 branches. Right superior bronchus has 3 branches, B1, B2 and B3. B1 is apical, B2 is posterior and B3 is anterior. Going down, truncus intermedius is here. After that, there will be B6 or superior segmental bronchus. Just below the superior segmental bronchus will be B star or called sub-superior bronchus, which is also have high prevalence. There will be middle lobe bronchus that will be lateral B4 and medial B5 in the same way. Finally, the basal bronchus will give rise to 7, 8, 9, 10. 7 is medial, 8 is B8 is anterior, B9 is lateral, and B10 is posterior. On the left hand side, our left main bronchus is here, and it will have a two division. One is superior division and other is inferior division, also known as lingular division. The superior division will give rise to B1 plus 2 and B3. So B1 plus 2 and B3 would be there, whereas the lingular division will give rise to two sub-segmental bronchus, B4 and B5. B4 would be superior, B5 would be inferior. In similar way as in right side, B6 would be superior segmental bronchus. Usually on the lower lobe bronchus or left side, the lower lobe bronchus, medial lower lobe bronchus or medial segmental bronchus would be missing, but also present in nearly 30% of the cases as best mentioned by Boyden. So this is the arterial system. You can see the right main pulmonary artery. It will give rise to truncus superior. A1 would be A1 would be true apical artery. A2 would be recurrent or either from ascending branch, and A3 is the anterior artery. Sometimes, as mentioned by Gossot, there may be ascending A3 artery also. This should be taken in very care to prevent the injury. The superior segmental artery would be there will be A6, whereas middle lobar artery would be A4 and A5, and sometimes there will be sub-superior artery, that is A star, and finally MALP, medial, anterior, lateral, and posterior arteries will be here. Similarly, on the left side, there will be left main pulmonary artery. First, it will give rise to A3. Sometimes mediastinal A4, A5 could be descending or springing down from here also. And unusual of the time, at the fissure, A4 and A5 appears like this. And the A1 and A2 would be common as a A1 plus 2A plus B together, or it may be separate like this. A1 plus 2A, B and C may arise on the lateral edge of the course of pulmonary artery. This is superior segmental artery, and there will be most of the time missing medial basal artery. Yet Boyden persistently says that it exists in nearly 30% of the cases, whereas Min Chang says that there will be prevalence of nearly 75% of medial segmental artery. I haven't mentioned that artery here, and there will be A8, 9, 10. This is anteromedial, this is lateral, and this is posterior. Regarding the venous anatomy, we can see here the superior pulmonary vein on the upper lobe, right side. So superior pulmonary vein will give rise to B1A, B1B, and B3B will be arising from here. Similarly, there will be the central vein. This is the central vein that will give rise to B2A, that is intersegmental vein between segment 2 and segment 1. B2B is intrasegmental to segment 2. B2C is intersegmental between segment 3 and segment 2. B22 is tangential branch that is running across the fissure. So this is the basic nomenclature that is followed by Lanchon, Boyden, Nomori. Everybody else follow this nomenclature. Please, you should remember this if you are willing to perform segmentectomy of lung. So this is for left lobe, left upper lobe, vein, and this is left inferior pulmonary vein. B7, B8, B9 all have A and B tributaries. For memory, B is either in between two segments or below the segments. Similarly, V10 you have all intersegmental tributaries A, B and C, important for aided soft segmentectomy but not of the scope for segmentectomy. Soft segmentectomy, if you are considering V10, the venous branches or tributaries, each tributary should be kept in mind. But if you are considering for just segmentectomy like today, as per our lecture, just they are all intrasegmental, so they can be sacrificed with impunity. So the concept of intersegmental and intrasegmental venous architecture was described by Overholt and Ramsay in 1950. It's like the adductor of clamshell. So intersegmental vein pass between the two segments or two subsegments, whereas intrasegmental pass through the segment. So while doing segmentectomy, you can sacrifice this intersegmental vein, but you have to preserve intersegmental vein so as to preserve the drainage of the neighboring subsegments. Let's start our small project, visible human project. So you can see the cross-sectional imaging on this very particular project. Now let's start the software. So this is the software of real human being. The cross-sectional imaging is, or cross-sectional cutting is done at every 5 mm. You can see here the annotation also can be seen. And you can see all the structures, available structures on cross-sectional imaging. This could be very much helpful for you people. And if anybody require it, I can share this software also. Now let's start going for the DICOM images, and I will be using Mimics version 26.0 to depict the segmental anatomy of lung. I have already segmented because of time constraint. The technique of segmentation would be shown in subsequent slides. So it is taking some time. I don't know why. Okay, it's opening. This is the segmented lung. This is the segmented lung here. You can see the segmented lung here. And our mass is, here is our mass. Tumor is on S6 segment. I'll show you how we have done it. So first of all, let's stop this all, as well as here also. So let's close it. After segmentation, you will, before segmentation, it is like this. Okay. Now we can see from the beginning, as in visible human project. So this is the trachea. Now let's follow the trachea. Lung starts appearing. Follow the trachea, follow the trachea, follow the trachea, follow the trachea. Now let's come to the catapult view. This is anterior bronchus, this is posterior bronchus. Let's see an airway also open. So this is the upper lobar bronchus, this is anterior and this is posterior. Right side, right? Let's see it here. Okay. Okay, this is anterior and this is posterior. You can see here, this is anterior bronchus, this is going to be two apical bronchus. So above it would be, above this catapult, there would be apical bronchus, right? This one is apical bronchus. Let's see it here, if it is true or not. Yes, of course it is apical bronchus. You can see here, this is apical bronchus. So So this is apical bronchus. This is anterior, this is posterior. Now let's come to downward caudal direction. You can see the fissure here. This is medial lobe bronchus here. This is medial lobe bronchus. Let's confirm it. Okay, this is medial lobe bronchus. You can see here, this is the medial lobe bronchus. And now this is the common basal bronchus, and this is going to give rise to segment 6 bronchus, right? This one is the first posterior division would be segment 6 bronchus. This is segment 6 bronchus. Let's confirm it. Okay, now this is segment 6 bronchus. You can see here the segment 6 bronchus. So basically we have right main bronchus. This will give to superior lobar bronchus. It has apical branch, anterior branch and posterior branch. This is medial lobe bronchus. Medial lobe bronchus also has 2 branches. One is lateral, other is medial. And this is superior segmental bronchus. Superior segmental bronchus has 3 branches. One is true apical and other is lateral, and one is medial. So sometimes there is subsuperior, or this is medial lobe bronchus, medial basal bronchus. Medial basal bronchus. This is medial bronchus, and this is anterior basal, this is lateral basal, and this is posterior basal bronchus. So on this image also you can see the cross-sectional imaging. Okay, this is segment 6 bronchus B6. After B6 it has to give medial lobe bronchus, medial basal bronchus. This is medial basal bronchus. Let's confirm it. Okay, this is medial basal bronchus, well confirmed. And now this is common basal. From common basal you will see different divisions. One is anterior, other is lateral, and one is posterior. So this one is anterior. Let's confirm it. So this is anterior, very true, truly mentioned, anterior, lateral and posterior. Similarly on the left side also, let's go towards the crouch. Okay, so this is the playboy view. This is the playboy view of the bronchus. So this is anterior bronchus, and this is apico-posterior bronchus. Superior division. This is the superior division of the upper lobe bronchus that will give rise to anterior bronchus, and this is common apico-posterior bronchus. Just above the apico-posterior bronchus, we can see this is apical and this is posterior bronchus. So this apical and posterior bronchus combine together like this. So now let's confirm it. Okay, so this is combined form of the apico-posterior bronchus. One is apical, other is posterior. This is superior division, and this is lingular division. Let's come to the lingular division here. This is the lingular, okay, apico-posterior. And now let's come downward to see the lingular division, right? This is lingular division of the bronchus. Lingular division also has 2 branches. One is superior, other is posterior, right? Superior and other is inferior. So this is lingular division of the bronchus. You can see it. The superior lobar bronchus will divide into upper lobe bronchus and lower lobe bronchus. This is lingular division, right? Okay, now let's come downward. So this is B6, segment 6 bronchus. You can confirm it like this. By segment 6 bronchus is this. Okay, segment 6 bronchus also has multiple branches. So after segment 6 bronchus, you can see here medial basal bronchus, anteromedial basal bronchus, lateral bronchus and posterior bronchus. So towards the vertebral side would be posterior, this is lateral, and this is anteromedial bronchus. So this is anteromedial, this is lateral, and this is posterior bronchus. So we have done this segmentation of the airway, bronchial segment, and now our presentation will be focused on the visualization of the mass and localization of the mass. So this is the long window you can see here. we have a mass here. We can see here the mass, right? So this is the mass. I have segmented the mass. This is the mass. The red area is mass. So we have to go for where is the mass. Let's three-dimensionally localize the mass. Let's visualize it. Airway is here. Okay. Mass is here. So airway is here and mass is also, I have to show mass also. Mass is here. Probably this mass is towards the territory, Bernoulli territory of segment 6. Now let's open the pulmonary vessel also. I have segmented it. Now let's see it here. Okay. So this is the segment 6. Now confirm it. Let's confirm it by left oblique fissure. You can see here the oblique fissure. Just below the oblique fissure there is the mass. So this is the 3D segmented lung we can see here, and now let's see the mass, airway and mass, the location of the mass. My 3D visualization is being off probably. So this is the mass. You can see here the mass, and we still don't know the territory of this very mass. Now let's put some first of all left oblique fissure. Okay, so this is our oblique fissure. So this mass has little bit invaded the oblique fissure. So let's come to the left lower lobe. Let's put it. Let's on the transparency. So we can see here the mass has invaded the oblique fissure as well as present in segment 6. The distance, the measurement, let's go to the measurement of the mass. So let's put the point here, enter here, and see this is the mass, and let's see the distance. The distance of the mass is about 13.26 mm. So I have to create a resection margin, safe resection margin of 26 mm. It's 26, okay, 27 mm. And let's put a sphere around this mass. So this is the sphere. So we have got a mass inside the sphere. This should be our resection margin. So this mass is present along the territory of the segment 6 bronchosaur B6 territory. So this is arising in the segment 6, and we have to go for segment 6 segmentectomy. Also see the vascular relationship of this mass. So here we can see that this is A6. This is the apico-posterior as well as anterior artery arising from main pulmonary artery. A1 plus 2A, A3, and this is A1 plus 2B. Whereas this is F4 and F5, lingular artery. You can see here the lingular artery, and the posterior division, that is A6. A6 also has 3 divisions. One is true apical, lateral, and medial division. So we can, without impunity, just tie this or sacrifice this A6 from its origin. Flush ligation can be done here. Regarding the bronchus also flush ligation can be done. There are 3 bronchial divisions, subsegmental division. One is B6A, lateral is B6B, and medial is B6C. Similarly, vein, B6 vein is traveling towards this or receiving the blood supply from the lung, oxygenated blood supply from the lung. So this is B6A, this is B6B. So what we can do here is we have to remove this intrasegmental vein but preserve this intersegmental vein. So this is how we plan, how we locate the tumor and undergo anatomical segmentectomy. Thank you very much.
Excellent talk by Dr. Sagar. We will now proceed.
We'll have some questions which have been put forward. I invite our other faculty, Dr. Vijay also to unmute and start his video. Let me begin, Dr. Sagar. Obviously, excellent, very in-depth lecture of how you go about interpreting the anatomy, which is the bronchopulmonary anatomy, and how you go on planning your segmentectomies. My first question to you is, I think I speak on behalf of all the faculty here. The number of patients who come to us who require a segmentectomy are very low, if at all any. We don't see the type of epidemiology like China or Korea or Japan sees. How is the epidemiology at your center? Do you get many such cases which are smaller than 2 centimeter peripheral early lung cancers which require segmented? You are, I think, we are unable to hear you.
Am I audible?
Yeah, please go ahead.
Oh, sorry.
Yeah.
So basically, we are also having similar problem. We don't have a lot of cases, but because of screening, and our center is the only center that perform lung surgeries in whole country. So all referral will be towards our center. So we get about 25, 26 cases a year for typical segmentectomy. But basically, we perform most of the time lobectomy, and only in selected cases we find the lesion that is less than 2 centimeter for segmentectomy.
Right. Before I go to Dr. Vijay, if he has any questions to you, we know you learned using the software. I think if I'm not wrong, you also invested a lot of time in part of development of such software as well. How important do you think that the surgeon himself does these 3D reconstructions before embarking upon a segmentectomy? And second part of that question to you is, how different do you find intraoperative approach to all this anatomy from how you plan in 3D? Because the way we see it, planning it in 3D is sort of like seeing a Google Maps that you will go from this place to that place. But once you are down on the road, so once you are inside the thorax, the learning curve may become easier, but not entirely similar.
Thank you for the question. Basically, what I find is that a surgeon must always perform CT segmentation and volumetry by himself. Even bronchoscopy should be done by himself. In our center, we do it by ourselves because we don't trust on anybody else for our patient. We don't get any kind of grants. That's our policy, number one. Number two is that while performing the surgery and sitting on the console, ourselves in the console, that will be very different. I already mentioned on my first slide that reflection deflection like Nakamura's digging technique or kind of opening book concept of Stephen Bench. If we have that kind of mirror image seated on your mind, if I reflect my organ towards other side or my segment towards other side, the topography would be like this. And you should think that for lung and liver, it's like a glass. Crystal clear. Whenever I reflect it, though bronchus is not visible or opaque organ, you should feel that, or surgeon should feel that this structure is going towards this territory. That's the thing. And we are very, very convenient in performing surgery after doing this kind of segmentation and volumetry ourselves, and we are doing it by ourselves.
Well, I think 3 questions have been asked on the software that you used by our audiences. So can you just mention which software you have shown us? And B, what are the other options of softwares that surgeons can, invest themselves if their institutes do not have a software suite in the radiology? What all softwares by their own they can go and download and use?
Yeah, there are many other softwares also. Few free softwares are also available. So you can get a 3D slicer, though it is freeware.
You get a lot of information using this software. Other is DICOM viewers are also there. Osirix is there in for Mac users, but I prefer Mimix. And what I want to add on is that your department of thoracic surgery or liver surgery, they should have a different suite, not connected with the radiology department, because that's not radiology department. That's your thoracic department, and you are dealing with your patient. You are going to do segmentectomy, not lobectomy only. So you should be very precise on doing surgery of segmentectomy, because if you just cut one intersegmental vein, then you will have a lot of trouble later. The patient will have in trouble, right? So in our center, we have different console. We have dedicated room, and our residents are well trained. And I myself had been to Malaysia to get training for this very software, and our government has got donation from other countries. So we have this kind of software. So if you are willing, then of course we can collaborate with each other, and I can also share the software too, but for limited people, for 25, 26, and we can arrange even the training session also. And we are going to join IASO NatCon in Lucknow. We'll meet there and we'll discuss about this later.
Perfect, perfect, Dr. Sagar. Dr. Vijayaraj, any questions from you on this topic or any comments?
Yeah, excellent talk. As we know that, as you already mentioned, that to get a CT 3D reformatted CT segmentation in regular cases would be very difficult for us. Since we don't have that software, I think we should look for collaboration so that we can get somehow the softwares available at most places so that we can perform precise segmentectomy.
Perfect.
Sure,
Thank you,
sure,
Dr. Sagar. So nice to have you. We look forward to seeing you and interacting with you at Lucknow at IASO NatCon. We
Thank you.
move on to our next speaker for today. We have Dr. Vijayaraj Patil, Associate Professor of Surgical Oncology from Kidwai Memorial Institute of Bangalore. And he'll be discussing with us the nuances of the surgical anatomy and how he approaches the lobectomies of the right lung. Over to you, Dr.
Just to lobectomies of right lung, we would like to thank IASO for providing an opportunity to share our presentation. Approaches can be divided based on anesthesia, site of approach, and access. Based on anesthesia, it can be intubated or non-intubated. Site of approach can be intercostal versus subxiphoid. Access can be open or minimally invasive, which can be thoracoscopy or robotic. Each can be uniportal or multiportal. Here we today discuss mainly about thoracoscopy. Before starting any lung surgery, double lumen tube is very important, and surgeon should also know about double lumen tube. The golden rule for double lumen tube is use opposite size new double lumen tube of appropriate size. Exceptions are present. The preoperative checklist is size by yourself, means by surgeon. Check the availability of fiber optic bronchoscope, because especially in 37 placement can be difficult without bronchoscope. And less available right DLTs, mainly of 35, 39 and 41 must be ordered prior, a week or 10 days prior. Post tube placement, during tube placement, surgeon, it is preferable to stay during OT. Confirm the tube visually that it is above the secondary carina, not into the tertiary carina. It is not too far inside nor too far outside. Auscultate yourself. Wait for a few minutes after isolation to check for desaturation before positioning the patient. These are key checklists. One of the basic principles of lobectomy is to handle pulmonary artery. We should know the difference between pulmonary artery, pulmonary vein and systemic artery. As depicted in the picture, pulmonary artery has a very thin wall and is formed by elastic lamina compared to systemic artery, which has muscular walls. As the muscular wall is not there, this artery is quite thin, and pulmonary system is high flow but low pressure system. Hence, while dealing with pulmonary artery, we have to be utmost careful, as this wall can fracture easily. Now here we depict how to dissect pulmonary artery branches. Here we are dissecting in the fissure. We have already divided the one of the branches of posterior ascending artery. Here we are depicting a central vein and posterior ascending artery. So the key for dissection is dissect the vessel away from the body. Means we have to dissect the body out of vessel rather than vessel out of body, so that we are not injuring the vessel. Here we are dissecting on the structures around the pulmonary artery, that is central vein and the nodal tissue. So once we dissect it, looping becomes easier without harming the thin walled pulmonary artery. Now we discuss about pulmonary vein principle, handling of pulmonary vein during lobectomies. pulmonary vein, as shown in the histological picture, has a very thick collagenous adventitia, which makes it a very thick walled structure. Unlike pulmonary artery, which is a very thin walled and fractures easily, pulmonary vein is very thick walled and sustains lot of traction and counter traction without harming. Now here we show you the basics of right superior pulmonary vein dissection. Here the mediastinal pleura is incised along the phrenic nerve. Then the pleura superior border of the pulmonary vein is defined by dividing all the fibrous strands between SVC and the superior pulmonary vein. The hook cautery is very useful in dissection of right superior pulmonary vein. Next principle is the lengthening the hilum. Once it is divided, all the fibrous strands around this thing is divided. Outlet is dissected. The party wall between the pulmonary vein and the pulmonary artery is hooked and divided to see a space between pulmonary artery and the pulmonary vein. Here we can see a space, then we can easily hook other layers and dissect the outlet. So we have defined the curve of the pulmonary vein. Next we go on to inlet dissection. Here again the same principles, all the fibrous strands are broken with the hook cautery close to superior pulmonary vein lower border. Once we see the inferior surface, we go along the inferior surface, take all the strands one by one and again see the curve. Once the curve is reached, we connect both the curves using a mixture forceps. Here we are pushing in the mixture forceps and seeing where exactly is the vein wall. Then slowly using the suction, we separate the vein wall from the mixture so that mixture can be passed behind the vein wall. Here we are dissecting so that the layer become thinned out. We come out, again we push in. At that time the layers would have gotten separated and then we are able to loop the pulmonary vein. We can dilate the inlet tracts for the stapler application. Now we have looped with the thread. Ideally it is not necessary for all cases. Looping in thread is better than looping with the vascular tape, as this can be divided with the stapler and we need not have to maneuver to remove it. The stapler is passed easily across the vein and vein is divided. Now we dissect the inferior pulmonary vein. Now the lower lobe is retracted upwards. Inferior pulmonary ligament is divided along with the nodes, if present, are swept along with the specimen. Or if it is a upper lobectomy, nodes are taken out separately. Then the posterior pleura around the inferior pulmonary vein is divided. This can continue up till subcarinal region to dissect the subcarinal node also. Now anteriorly we go in between middle lobe vein and the inferior pulmonary vein and dissect and loop the inferior pulmonary vein. The stapling of inferior pulmonary vein is standard. We get it through the access incision and pass it across this thing and divide it. Case 2, here we are dividing again the same maneuver we are doing and dividing the inferior pulmonary vein with the stapler. This is an Ethicon PVS stapler. But after division, we have a surprise that segment 6 vein is still not yet divided. Hence we divide it again. If we look at both this thing, here this inferior pulmonary vein was not completely dissected.
The right lung fissures. There are two fissures, oblique and horizontal fissure. Oblique has two parts, anterior and posterior. Fissures are classified by Craig Walker into grade 1, grade 2, grade 3 and grade 4. This is of no surgical significance at all, because for us interlobar artery visualization is the key, which is not addressed in this classification. Another simple classification is complete and incomplete, fused and not fused, but there is no surgical classification. Surgical classification is because only when interlobar artery is visualized, our surgery becomes easier. When interlobar artery is not visualized, surgery will be slightly tricky. So there is no surgical classification for fissure. Fissure anatomy can be divided into a mediastinal entry and interlobar exit, which is guarded by mediastinal guards or interlobar guards, and transfissure structures. As there is a guard of honor in cricket through which the celebrity passes through, similarly there is a guards which between which the staple line has to pass through. Horizontal fissure, the guards on the mediastinal are mid-lobe vein and superior pulmonary vein. Similarly, on the interlobar side are mid-lobe artery and the central vein. Oblique fissure has anterior and posterior parts. Guards are different for each part. Anterior part, the guards on the mediastinal surface are middle lobe vein and lower lobe vein. The guards on interlobar surface are interlobar artery after division of midlobar artery. Guards of the posterior part of the oblique fissure are interlobar side, it is segment 6 artery, and superiorly it is posterior segmental artery. Similarly, posterior guards in case of oblique fissure are right upper lobe bronchus and bronchus intermedius. Here we are showing a horizontal fissure which is very thin. Usually horizontal fissures are very thick. Here horizontal fissure is very thin, which is easily divided by rigashore. Here we can see that all the guards are easily seen after division of parenchyma. All the guards are seen. This is a thick fissure which is between the upper lobe and the middle lobe. Here first we are dividing the parenchyma, which is free with along the fissural line with the 60 cartridge. Next, the cartridge is placed inferior to the cut edge of superior pulmonary vein and over the middle lobar artery. The correct positioning of the staple anvil is the key for division of the fissure. Here we are dividing the fissure above the middle lobar artery. Then a small twig of parenchyma would be remaining, which can be divided with a scissor. Here we are depicting a fissure division with vein in situ. Here we are dissecting along the superior pulmonary vein, inferior border, make a tunnel for the staple anvil to fit in. First we fire a stapler, usually we fire with 45, keep the anvil over the superior pulmonary vein and divide the parenchyma. Then after the division, then again we open the space between the inferior border of superior pulmonary vein and we expose the middle lobe artery. So once the middle lobe artery is exposed, again the staple anvil is positioned in between middle lobe artery and the central vein and parenchyma is divided. The small twig of parenchyma is, a small sliver of parenchyma is divided with ligashore. So here we can see the mediastinal guards and also the interlobar guards. Okay, fine. So in this CT, we are depicting transfissural vessel. Here is the basilar artery, which is giving rise to lingular artery, which is passing across the fissure and supplying the lingular lobe. And also the lingular vein is also passing across the transfissural course. While dividing the fissure, these transfissural arteries can be problematic since it can devascularize the other side of the remnant lobe. Here we are depicting a transfissural vein, which is crosses between the oblique fissure. Right upper lobectomy can be done in varied sequences. Commonly followed is fissure, followed by posterior ascending artery, vein, truncus and the bronchus. But sometimes when the fissure is fused and interlobar artery is not seen, vein, we follow vein, truncus, bronchus, posterior ascending and fissure. This is called fissureless technique. But this technique has an inherent risk of misidentification of the pulmonary arterial branches and hemorrhage is one of the risk factor. Other way is the fissure, posterior ascending, bronchus. You complete the posterior part, then you divide the truncus and the vein. We can use a 60 vascular stapler to divide both together in this approach. Upper lobe is supplied by, has 3 segments, A1, A2 and A3. It is supplied by truncus anterior and posterior ascending. The truncus anterior can have 4 branches, 2 branches or single branch. Similarly, posterior ascending can be single or multiple. This is the pulmonary artery posterior ascending branch, which are 2 in number, which are arising at the level of middle lobar artery. Posterior ascending artery variations. Posterior ascending artery can be anterior to central vein. Here in this case, it is anterior to central vein. Posterior ascending artery can be posterior to central vein, as in this case. Or variations can be that it can be both anterior and posterior to central vein. So these are the variations of the posterior ascending artery. Here we are depicting the variations of truncus anterior branches. Here is the truncus anterior, which is giving rise to 2 A3 branches, 1 A1 branches, 1 posterior recurrent branch. This is the case of a segmentectomy where we are dividing the A1 branch, which is supplying the apical segment alone. Here we are dividing it with a stapler. We can see the recurrent A2 branch, which is crossing the bronchus from behind. Right superior pulmonary vein, divide the pleura adjacent to the phrenic. Then with the hook cautery, divide the fibrous strands which are on the lower border of the superior pulmonary vein and define the curve of superior pulmonary vein. Then you go along the superior surface of superior pulmonary vein, divide all the fibrous strands which are connecting
then loop the superior pulmonary vein and divide it with the stapler. The truncus anterior dissection can be done along with the superior pulmonary vein or can be done individually separately. Again, the same principle. Go on dividing the soft tissue and the pleura along the SVC and the azygos. Here again we are dividing the soft tissue and fibrous strands between the SVC and the hilum. Divide all the strands so that the pulmonary hilum stands bare and lengthened. Now here we are using ligashore to dissect the soft tissue between the bronchus and the right main PA and dividing this soft tissue. Dividing this soft tissue has two purposes. One is allows dissection of the node and also allows dissection of the truncus from the bronchus. We have to dissect truncus usually adhered to bronchus. Once this layer is divided, it is moved away from bronchus and we get adequate space to dissect off the truncus and loop the truncus. Here again we are using node as a guide for us to dissect along the node rather than artery. Go along the node and loop the truncus anterior. Once the truncus anterior is looped, we use Ethicon vascular stapler. We rotate and place the staple along the truncus, but we feel that it is hitting the azygos. Then we reticulate up, then push it further so that the truncus is divided safely without azygos. Here we are dissecting the posterior ascending artery, which is behind, in this case, behind the central vein. We are dissecting the posterior ascending artery. Since the access is slightly difficult, here we are dividing a V2 branch of vein with the sutures and dividing it. After which the access for stapler becomes much easier and posterior ascending is divided. After division of all the vascular structures, now we dissect along bronchus intermedius so that all the nodal tissue is swept across towards the specimen. Here we are dividing the sump node. Then the fibrofatty tissue along the anterior surface of right upper lobe bronchus is swept towards the specimen. Now we divide this with purple stapler. If it is a right main bronchus, we use black stapler, but if it is a lobar bronchus, we use a purple stapler, which is passed across. We will clamp the stapler and then look for ask the anesthetist to make double lung and see for inflation of middle and lower lobe. Once it is confirmed, then we divide the bronchus. This is a post-op X-ray of a patient who has underwent open right upper lobectomy for a post-chemo right upper lobe cancer. Post-op day 2 X-ray shows a white shadow along the mediastinum, suspecting middle lobe torsion. This patient underwent CT scan, which showed that there is middle lobe consolidation, and the bronchoscopy done shows narrowing of middle lobe opening. But however, this patient had the middle lobe fixed to the lower lobe. So that is the key step in avoiding or reducing the middle lobe consolidation. This is the patient who has underwent right upper lobectomy for a dense carcinoid tumor. Post surgery had developed hydronemo, which is in the apical part of the right semithorax. This patient, this mainly occurs due to inadequate release of inferior pulmonary ligament, so that the upper middle and lower lobe doesn't fill up the upper cavity. So ideally, it is preferable to divide the inferior pulmonary ligament. And second thing is, placing an ICD at the apex after doing an upper lobectomy also helps to avoid such scenarios. But evidence say otherwise, that inferior pulmonary ligament release may not necessarily contribute to the obliteration of dead space. This is an RCT which has shown that preservation versus dissection of inferior pulmonary ligament after an upper lobectomy has not given favorable results. Also, division of inferior pulmonary ligament is known to alter the axis of the remnant bronchus, which needs to be studied in detail in future. Here we apply the principles of lobectomy for doing a middle lobectomy. Here we are dissecting the anterior part of oblique fissure, which is not so thick. We are dissecting between the middle lobe vein, interlobar artery, and the bronchus to dissect the space, which are the guards for our fissure, which towards interlobar side, middle lobe vein, bronchus, and interlobar artery. Once this space is created, we move along towards the mediastinum to create the mediastinal, expose the mediastinal guards. that is middle lobe vein and inferior pulmonary vein. Once the soft tissue is divided, the dissection of fissure becomes easier and is divided with stapler, purple stapler. Now the interlobar artery is dissected close to the middle lobar artery, taking along with the interlobar nodes. Then the middle lobe vein is dissected off from the superior pulmonary vein and looped. Here we can see the horizontal fissure is fused. Hence we are dissecting along the superior pulmonary vein to make space for stapler division. First stapler is fired, then again along the superior pulmonary vein another stapler is fired, and then here we are, the middle lobe has a small part of fissure which is between the middle and the upper lobe, which needs to be cleared at the trifurcation of middle, upper and the lower lobe. Once that is cleared, the exit for the staple is cleared. Next, here we go along the central vein. Here we are finding for the guards on the mediastinal surface of horizontal fissure, middle lobe vein and superior pulmonary vein. Then along them we are going towards the interlobar guards, which are the middle lobe artery and the central vein. Once the space between them is created, we can loop the whole fissure and loop it with a thread and then divide it with a purple stapler. Then the middle lobe arteries are dissected off from the mediastinum and then looped. This is the middle lobe vein which is being divided. Then middle lobe artery is looped. There are two middle lobe artery, A4 and A5 separately, which are divided individually. Once the artery is divided, the bronchus is dissected off from the interlobar artery. Then maximum length is gained and then divided with stapler purple. Here we show the right VATS lower lobectomy. Here we are dividing the fissure layer by layer to reach the interlobar pulmonary artery. Again, we have to see segment 6 artery, which acts as a guard for our posterior fissure. Then we dissect along the medial surface of the interlobar artery and dissect off the node, which are interlobar node along the interlobar artery to dissect the anterior fissure. The principles of anterior fissure has already been discussed. Here we are dissecting the posterior fissure and staple divided the posterior fissure. The interlobar artery is dissected and then divided. Fissure is divided with the stapler. Lower lobectomy is technically more easier compared to other lobectomies. Here we are dividing the inferior pulmonary vein with a vascular stapler. Then the last structure, bronchus, is divided with the green stapler. Here we are showing the bronchial division in a case of right upper lobe sleeve resection for a case of carcinoid tumor. Here we are dividing the bronchus intermedius vertically. Ideally, it has first cut has to be with the knife. After that, we can use scissors to divide the bronchus intermedius. Here, bronchus intermedius is divided in a step-by-step manner. The last soft tissue contains the bronchial artery, hence divided with Ligasure. Then the proximal margin, which is towards the right brain bronchus, is divided with the scissor. Here we can see that the DLT is being seen. Now the proximal margin, remaining proximal margin is divided. So the anastomosis we do with the barbed sutures. This is inside out, outside in. The first knot comes inside. Usually the first knot doesn't tighten fully. Then we continue the knot inside out on the main bronchus side and outside in on the bronchus intermedius side. Similar sutures are taken continuously. Each suture has to pass through full thickness of the cartilaginous wall on both sides with minimal cheating so that the luminal mismatch is adequately approximate. The key area of the sleeve resections anastomosis is the angles. Here we are still taking a bite and reaching towards the angle. Once we reach the angle, we leave the thread and start on from the opposite side, inside out, outside in, with the barbed sutures. Then again, going from inside out, outside in, we continue continuous sutures, which are taken again through the cartilaginous, through the membranous wall, with adequate spacing to avoid luminal mismatch. Again, we start with a third barbed suture at the angle where we have left. This bites become quite easier at the angle of once we take a new suture. The old suture is knotted onto the new suture. Then we continue from outside in and inside out bites. We keep the sutures loose so that the last part of the bites, which can be taken under vision. Once adequate number of bites are taken, the suture is tightened. Since both the needles are on the same side, we take a backhand stitch to reach the opposite side and then knot both the sutures. Knotting is not ideally advised for the barb suture, but still we take knot for the security, and the needle is divided. Air leak test is done and there is no air leak. This is our publication on sleeve resection. We have done close to 30 sleeve resections with no major anastomotic complication. One patient had the post 30-day mortality. Cause is unknown. I thank the organizers for providing opportunity, and I thank Dr. Karthik, Rajeshwari, Nagashri, and Aparna for helping me out with this presentation. Thank you.
Right. Thank you, Dr. Vijay. Over to the questions. I think the first one that we have is about the position of the patient and the position of the port.
Regarding position of the patient would be a right up position with the bolster at the level of nipple region, and the port would be at fourth intercostal space between anterior and mid axillary line, one port, and another camera port at the level of seventh intercostal space in the mid axillary line.
Right. So a two-port approach. Now, the common questions that we have following these surgical tutorial videos is, the first one of them is, during your learning curve of these procedures, which would be the VATS lobectomy or even open, what were the common earlier misconceptions or mistakes that you encountered, which you feel, the other trainees also sort of repeat, and now you train them that they should not do this? Hello, Dr. Vijay. Dr. Sagar, are you able to hear me?
Yeah,
Hello.
I'm hearing you.
Okay. Dr. Vijay, are you there?
Hello.
Hello. Hello. Anyway, while he's connecting back, Dr. Sagar, is your approach at your center also VATS? Is it biportal? Is it single port? Do you do robotic? What is your preferred approach for a lobectomy, a straightforward lobectomy?
Basically, we don't have robot on our institute, and we are very much planning to get one robot, one very good way for us. And before we used to do dual port bats, and now we have gone to the uniportal bat system. Since about 3 or 4 months back, we have started, after going to train in Shanghai Chest, and we have started uniportal bats.
Perfect. Perfect. Dr. Vijayaraj, are you there? Are you able to hear us?
Yeah, I've come back. Yeah.
Perfect.
Yeah.
Perfect. So I think the question that we were discussing were the learning points during this procedure that you have learned over time, mistakes that common, trainees make during this procedure.
Yeah, the one was the fissure. Making fissure, if we know to divide fissure and approach fissure, that is the most rate limiting step. One. Second is use of staplers and correct angles. So the all the confusing which angle, how to retract the lobe, how to push the stapler in, and how very key to lessen the learning curve and to achieve a decently safe and smooth surgery.
Perfect. Regarding the post-op care, for a uncomplicated lobectomy, how many drains do you put? Do you decide the number of drains based on which lobectomy, upper or lower? And what is your criteria for drain removal after lobectomy?
Regarding lobectomy, usually uncomplicated, simple, straightforward lobectomy, it would be a single drain. If a patient is emphysematous and I have done a right upper lobectomy, then I would put a second drain towards the apex of the thorax. Then other thing would be air leak. If there is a lot of adhesions and we have done extensive adhesiolysis, then also I would prefer to put a second drain. Regarding the removal of the drain, it should be drain output less than 2 ml per kg body weight is our criteria, and there should not be any air leak. These are the two criteria which we keep for removal of drain.
All right. With that, I would like to thank you, Dr. Vijay. I request you both of you to stay till the end of the third lecture as well. We move on to the third talk for today, and that is going to be on the surgical anatomy of the left thorax and the approaches to the left lobectomy. And the speaker is going to be Dr. Saruna Rajmanikam. Over to you, Dr. Saruna.
Today we will be discussing about anatomical considerations of left-sided lobectomies. Planning is key when considering surgery for left-sided tumors. We need a thin slice CT scan, a bronchoscopy, EBUS staging, PET-CT, MRI brain, and biopsy, which forms the cornerstone of cancer evaluation. In addition to that, all of us must know that a proper physical fitness must be taken with 2D echo, pulmonary function test, a DLCO, and in some cases a VO2 max in cases whom we think that there will be some difficulty in surgery. The key differences between left side and right side are that you can see on the right sided anatomy, the bronchus is behind the pulmonary artery, whereas on the left side, the left upper lobe bronchus actually originates in front of the arch of the left pulmonary artery. And that makes it difficult, and especially when there are a lot of nodes and adhesions, especially during chemoimmunotherapy cases, where we find that the nodes which are around the left upper lobe get stuck on the pulmonary artery, resulting in a sleeve resection of both bronchus and the artery in such situations. In addition, I would like you to take note of the blood vessels of the left side. You can see that the left upper lobe receives multiple branches, sometimes up to 7 branches from the pulmonary artery, and the lingular artery is usually a very constant artery which divides into superior and inferior lingular arteries, but proximal to the lingular artery you have up to 4 branches that may arise from directly the arch of the pulmonary artery just above the left upper lobe takeoff. So we should note this and we should identify this even in the CT scan and the preoperative planning so that we know what steps to perform, how many arteries, and the planning that we need to take while performing these resections. If you go to the lower lobe, you can see over here the superior segmental artery in many cases is taking off directly opposite to the takeoff of the lingular artery. So sometimes the transection of the lower lobe pulmonary artery may be in a angulated way rather than a tangential transection to the pulmonary artery. So we need to take note of this, and this anatomy is variable from patients to patient. The venous anatomy is actually best seen in the sagittal and coronal images. You can see there are multiple variations of the venous anatomy. On the left side, we should be very clear of the drainage of the lingular vein because that is the key to both left upper and left lower lobectomies and segmentectomies. The lingular vein sometimes may directly enter into the upper lobe pulmonary vein, sometimes may directly enter into the lower lobe pulmonary vein. And in about 10 to 12% of the patients, lingular vein may directly enter into the pericardium, having a separate entry into the left atrium. So these reconstructions from the CT scan can delineate and help you plan the surgery depending on the veins. Transection of the lingular vein inadvertently may lead to congestion of that particular segment or lobe which doesn't have proper drainage, but invariably many times we see collaterals develop and no serious issues happen, but we need to safeguard. This image actually shows you the arterial anatomy again. You can see the takeoff of the first branch, second branch, third branch, and the anterior branches of the pulmonary artery and the basilar segments. Although it is difficult to delineate the vessels on CT scan and teach it in this particular video, we can actually trace the main pulmonary artery from the left side and identify individual branches which are coming off, which helps us in surgical planning. For this, we need to have a good arterial face CT scan so that we can differentiate between the aorta, the pulmonary artery, and the pulmonary veins and the heart, and delineate the anatomy in our pre-op planning. These are my principles for left-sided surgical resection. We start with the posterior mediastinal pleura release, which is also called the hilar release. Then I do the anterior hilar release followed by lymphadenectomy. Doing a lymph node dissection initially skeletonizes all the structures which are required for removal of that particular lobe. Following which we go after the fissures. If the fissures are well developed, if they are not well developed, we do them last. On the left side, we must, like I mentioned prior, identify the lingular artery, lingular vein, and their anatomical drainage and supply, because we need to identify and take off only those vessels which are going to the upper lobe or the lower lobe accordingly. So then, depending on the anatomy and the difficulties we face during surgery, I usually take the pulmonary vein first and then followed by arterial branches, or the arterial branches first following by the vein. It depends on the anatomy, and each individual patient gives a different outlook, and the sequence may change. And following this, we complete the bronchial traction, which completes the lobectomy in these patients. We will now start with the left upper lobectomy. The first step in any lobectomy is actually the posterior hilar release. You can see I'm releasing the mediastinal pleura between the aorta and the lung posteriorly. The white structure is actually the vagus. Once you identify this structure, it's a guide to your entire hilum. So what it does is you can actually, all the nodes which are medial to the vagus are the ones that need to be resected while doing a left upper lobectomy. You can see the node that is popping out there black is actually the 11 lymph node, which is exactly on the pulmonary artery. Just below my instrument, that white shining structure is the left main pulmonary artery. So the posterior hilum is classic in that you have, from cranially to caudally, you have the left main pulmonary artery, then you have the left main bronchus, and in the inferior part you have the inferior pulmonary vein. All these nodes are taken individually so that you can identify the stations, and the pathologist also is given a proper sample. Now you can see, especially in the Indian patients, between each anatomical structure, named anatomical structure, you will have lymph nodes. Now what I'm doing is actually dissecting between the lower border of the left main pulmonary artery. You can see the orientation with the vagus and opening up the plane between the in the periodontial plane between the main pulmonary arteries. Once you remove that node which I was dissecting earlier, which was between the left main bronchus and the pulmonary artery, you enter into this layer and then completely skeletonize the vessel as much as possible. Now comes the portion of anatomical dissection of the fissure. You can see over here, we have done the posterior hilar release, and now because we've done the posterior hilar release, once we've identified the pulmonary artery in the fissure, we can immediately see where we have to staple or coagulate and cut. Here in this patient, for teaching purposes, it's a very easy case, so you are able to dissect the entire fissure with just bipolar cautery. If it's thick, then what we do is we just put a stapler and transect that portion between the left upper lobe and the superior segment of the lower lobe. Then what we do is completely take the lymph nodal tissue and delineate all the vessels which are going to the left side. You can see over here, there are 3 branches that we can actually see there. The smaller branches I usually don't staple because tractions can cause injury to the main pulmonary artery. Here I'm just tying, and my rule over here for both airway and bronchial transection is a 5 millimeter rule. A 5 millimeter rule is that you always keep the knot or the transection point not exactly at the branch point but 5 millimeter away from the branch point. You can see the second vessel over here, that is another branch going to the posterior segment of the left upper lobe, that is also being tied, and here you can see what I'm emphasizing. The knot is 5 millimeter from the branch point, and the coagulation is also 5 millimeter distal to the knot that I have tied, so that in case of any mishap or any problem, you can actually tackle it by holding it or by clipping it or by suturing it. If you tie it exactly at the branch point, there is a chance of avulsion. So you've taken 2 posterior branches, and now the branch which was very close to the camera was actually the lingular branch, and this is being stapled. You can see just by looking at the structures, you can identify what decision you have to use for ligating that particular vessel. Those 2 smaller vessels I ligated with suture, and the larger lingular vein I stapled. Then we move forward. You can see over here, this is the anterior hilar release. In the anterior hilar release is releasing the mediastinal pleura between the phrenic nerve. You can see the phrenic nerve to the left of my left-handed instrument. It is below that structure, white structure linearly passing from above downwards is the phrenic nerve. And just medial to that, you actually go and identify the vessel. Here you can see we are actually transiting the upper lobe pulmonary vein. In this particular patient, the lingular vein was draining into the upper lobe pulmonary vein. We identified that in the anterior hilum before we take a decision on transection. Once we are sure, then we close, and mostly major pulmonary veins I prefer to take using the staplers. Don't use any clips or suture techniques for this particular pulmonary vein because the pressure is quite high and there are chances that your knot may slip off in the post-op period, or when he or she coughs, or the clips may also go away. After this, you can see we've released all the posterior branches of the left upper lobe, and the only remaining branch is actually the apicoposterior branch. There are variable branches here. This is S1 plus 2 plus 3 and branches. So this is A1 plus 2 plus 3. You had different additional branches to the posterior lobe, and such a large vessel, better to transect using a stapler. So you just have to tease, relax your traction, pass the stapler across, and completely transect the upper lobe pulmonary vessel. Once you do this, you can see in most lobectomies, planned lobectomies, we usually do bronchial transection last. Once we do the transection, what happens is it opens up the entire anterior part of the pulmonary artery, and everything can be done under the vision. Sometimes to dissect around the vessels and to dissect around the bronchus may be difficult. So that is why I mentioned do a hilar release, do anteriorly, posteriorly, cranially between the aorta and the main pulmonary artery. And once you completely are able to flip the lung is when you will get maximum traction and counter traction to dissect all the vessels. Now, once the vessels are taken off, you can see we have taken off the vein which is stapled and seen to the anterior part of the bronchus. We are now going after the left upper lobe. Like you saw in the diagram before that I depicted, you can see now the arch of the pulmonary artery and the left upper lobe is coming from anterior to the pulmonary artery. So this is classical of the left upper lobe. And we again apply the 5 millimeter rule over here. You can see the stapler is going in and I am looking like this so that you can see there it's 5 millimeter away from the branch point. If you leave out more, there is a chance of devascularization of the stump and there may be stump issues like blowout or leaks. So I sincerely suggest that you keep only 5 millimeters away. Now we'll move on to the lymphadenectomy part. The lymphadenectomy part you can see is just above the, this is station 4 and 5 dissection. We just follow the vagus like I am showing you here. Follow the vagus slowly and go cranially. And when you go cranially, what you will see is you will see two structures which are separated and coming and the left recurrent nerve will be taking off from that particular zone. You can see now slowly the left recurrent nerve is coming under view. Use bipolar energy, dial down the cautery to the least possible setting, and if at all there's any ooze or bleeding in this region, my suggestion is to just place a gauze piece there and come back again and not meddle with it, so because you need to preserve the left recurrent nerve. All the nodes in this station you can see come from just above cranial to the pulmonary artery to just underneath the arch of the aorta, and the structure which I am actually dissecting now is the patent ductus arteriosus, and the medial boundary is actually the phrenic nerve. So you can see this triangular zone which appears between the vagus nerve, the phrenic nerve to the left, the vagus nerve to the right, and the arch of the aorta which forms the base of the dissection. So station 4 and station 5 are taken out in this manner. As you go deeper and deeper, what will happen is you need to be very clear about the anatomy. The 4L station is just underneath the arch of the aorta, and you need to take precautions because there may be traction injuries to the left, the recurrent laryngeal nerve when you are doing this dissection. So here we have removed the subaortic station, and all these nodes are bagged separately and taken. Now you can see there the left recurrent, to the left of my instrument is actually the patent ductus arteriosus, and to the just the Maryland is dissecting in between the PDA and the 4L station lymph node. So the 4L station lymph nodes come from there. This can only be achieved by medial traction of the entire pulmonary artery to one side, and my instrument is now touching on the phrenic nerve, and you can see there the innominate vein can be seen, and the nodes in the 4L station are taken out from here. It's very difficult to dissect and remove the 2L station, and that's why if a node is present in the 2L station, I generally prefer to do a mediastinoscopy and remove that station, because from the left thorax sometimes it's very difficult to access the 2L station, whereas the 4L station is actually accessed from here in between the patent ductus arteriosus and the recurrent laryngeal nerve, which you can see coursing underneath the arch of the aorta and going recurring into the towards the neck. So this is a very careful point of dissection. You need to be very slow. Any bleeding, like I mentioned, just keep a gauze and keep the area bloodless, keep the cautery to the lowest moment. And this is particularly why I like using the bipolar instrument for this particular part of the surgery. Sometimes the subcarinal node is the most difficult station to do because it is so deep. This is for you to understand here. My left hand is actually pulling the left main bronchus behind. Subcarinal node is best dissected before transecting the bronchus. So you go in exactly anterior to the vagus. You can see the vagus is to the right of my Maryland instrument. And then what happens is you find in the depth you will find the nodes, and keep a gauze piece because there will be bleeders there. I don't know whether you can see over here, but in the robot it's very nice, and you can see in the depth, and go up to the right main bronchus from there. So to the right of the Maryland will actually be the esophagus, and the white structure which is seen in the depth is actually the right main bronchus, and we remove all the tissue that comes out of the that particular zone station. So in general, I find that the left subcarinal node is the most difficult area to access on the left side, and you need to know your anatomy thoroughly to get these nodes out. It's very critical because we see a lot of resection recurrences in this region, because what we think is the subcarinal node is actually the inferior pulmonary ligament node or the paraesophageal node, and not the classic subcarinal node. So you need to go to the depth, see the right main bronchus, and take all these nodal tissue off that particular bronchus, and then only you will have a complete subcarinal lymph node dissection. We'll move on to the left lower lobectomy. In the left lower lobectomy, you can see the inferior pulmonary vein is the inferiormost structure after you do the hilar release. We go across the left lower lobe pulmonary vein and then transect the vein after we completely identify all the structures which it is draining. Always look at the lingular vein and check where it is going. You can see we've passed our instrument across, and we'll slowly be stapling the inferior pulmonary vein now. So that is mostly the first part of the operation, and once we do that, the entire lower lobe actually gets released, and we can continue in performing a fissure-less resection. This is a classical step we do in the lower lobe, because the left lower lobe is the easiest lobe, and what we do here is actually transect the entire left lower lobe pulmonary vein first, and this opens up the entire view. Here we've completed the lymph node, the fissure division, and I just wanted to show you for the anatomy sake. It's very critical to go into the periadventitial pain over here, and the anatomy over here you can see this is classically representative how different the anatomy is on the left side. You can see the lingular artery is actually branching off the pulmonary artery after the segmental branch, which is seen in the distant end. So that's why we need to know exactly. So in this particular situation, a single transection is not will actually occlude the lingular artery. So in this place, mostly what I'll be doing is I'll dissect all the nodes, periadventitial tissue. Try to go across the basilar artery, which is seen proximally. Take the soft instrument and go across. In VATS, you have long instruments where you can just go across. In robot, what we do is we tend to use, a peeling kind of technique. And once we've done that, you can see we are looping the entire basilar trunk. And what is left behind, which is still going to the lower lobe, is actually the segmental artery. We are now removing the nodes from there. In between, there are nodes between the segment 6 and the basilar trunk. And now we've taken a sling completely around the entire lower lobe artery and see the angulation which is required for stapling this. So in this situation, we want to make sure that we are not occluding any branch to the left upper lobe. So we'll see this is one place where I would use the indocyanine green. So I use indocyanine green after transection to ensure that the lingular is receiving its blood supply, and then we staple the particular vessel. So these safety measures you need to know, and especially when there is a proximal takeoff of the superior segmental artery from the main pulmonary artery. Here, and finally what happens is the bronchus. You can see now once we free the vein and we free the artery, we do the bronchus slowly. Again, a 5 mm rule is followed. We follow, especially in the lower lobe. My suggestion is when you go across, sometimes you may take across the left main bronchus also. When you're doing a lower lobectomy, always make sure you do an inflation test after occlusion of the left lower lobe bronchus, so that the entire upper lobe, you can see it is inflating. You can ask anesthetist to ventilate the lung, and the specimen can be taken out. Just moving on to upper trisegmentomy, I'll go quite quickly, because here the individual branches we know from 3D reconstruction. We take the posterior branch going to the upper lobe. We preserve the lingular branch, and what we do in this situation is, so after we take the artery and vein to the particular branches, here I just like to mention, because there's no segmental delineation on the surface of the lung. So after we've taken the artery and vein, we use indocyanine green, because arterial occlusion has been done already. And within 10 to 15 seconds, we need to mark out the segmental anatomy, and because there is sometimes collaterals, and you will see cross perfusion from the vein, and then we transect according to the marking. We completely transect the lobe, and sometimes we need more number of staples to do the transection, and finally we go after the bronchus and we do the bronchial transection. A small point about sleeve resection: the anatomy that I showed is just self-explanatory. In sleeve resection, what we do is we transect the upper lobe. Here we are doing a left upper lobe sleeve. We are transecting the lower lobe from the inferior cut is being taken. The pulmonary artery is seam upwards. We've already taken the vein and the arteries, and you can see what is left behind is actually the open end of the left main bronchus and the lower lobe bronchus. So once we remove the specimen, you can see what we are doing is we are actually doing a sleeve resection. A sleeve is actually a resection in which the ostium is involved. So we remove the ostium along with the bronchus, and that leaves us, and we'll have to do an anastomosis in this situation. So we are reconnecting the left upper lobe to the left lower lobe bronchus, and this can be done open, this can be done VATS, and can be done by robot also. The robot gives a very good view and good dexterity to do precise bites and take an anastomosis here. So you can see always before you do complete the transection, I usually put the posterior layer and check for vascularity so that you know that the entire anastomosis is well perfused. So this is the final bites which are taken. We took the posterior layer first, and now we are doing the anterior layer. And each of these bites can be taken precisely. And I knot near the far end. The sutures that we're using is actually barb suture. And we check for air leak and come out. I'd like to just mention over here the importance of identifying the lingular anatomy. Here you can see we sling the left lower lobe pulmonary vein. And but we actually found that here the vein is actually, the lingular vein is going on the lower lobe and draining into the lower lobe pulmonary vein. So in this situation, it's very critical that you actually identify the vascular anatomy, preserve all the venous structures which are draining in the lingula. And this video is on YouTube, you can see it. It's very essential before you transect the lower lobe pulmonary vein. You can see there, if I had taken the lower lobe pulmonary vein in the normal area, I would have transected this lingular vein. Here we are able to identify and dissect, and now we are going to transect distal to the takeoff of that particular vessel. And here, because the medial segment was completely drained by the lingular vein, we are now creating a transection of the inferior pulmonary vein distal to that particular vessel. So it's very critical to identify the anatomy of the lingular vessels before, both the arteries and the veins, before you do a upper lobectomy or a lower lobectomy. Pneumonectomies are rarely performed now in our institution, but we still do them, and that is just a combination of all these. Just to keep it short, I would like to mention these are the tips that I live by. Encourage the anesthetist to put the opposite side double lumen tube. Always use a right side double lumen tube, because there are a lot of mishaps that can happen when you do left-sided double lumen tube. Another issue is mobility of the lung. If you put a left-sided tube, you can't mobilize the lung, and dissection of the lymph nodes it becomes a little difficult. So, and blockers, sometimes I have made mistakes by stapling blockers. So make sure that if you're using a blocker, ask the anesthetist to pull out the blocker when you're doing the final transection. Find the vagus at all times. Identify the vagus and the phrenic, because these are the gateway to your lobectomy, both upper, middle, lower, and on both sides. And whatever important structures are in between these two. So finding this and identifying them is very critical. Don't start vessel dissection or bronchial dissection before you're able to flip the lungs both. You can see in both the videos, we were able to flip the lung medially, posteriorly, anteriorly, upwards, downwards. And if you're not able to flip the lungs, don't start your lobectomy. I always follow a 5 millimeter rule for stumps, because for both vessels, in case of any problems, you can manage them, and for airway, to prevent bronchopleural fistulae. Anything longer than 5 millimeter can cause devascularization of the stump. Try to lengthen the vessels. I always say lengthen at least 2 to 3 centimeters of the vessels before you pass your staplers, because passing through inadequately dissected vessel can cause stump avulsion. I've had it, so my advice is to lengthen the vessel before you go and transect. Like I mentioned, use ICG and inflation testing for safety to identify which lobe and which area you're preserving, so that you come out with a safe lobectomy. With that, I'd like to thank you and the IASO members, Dr. Srijan, the Indo-American team, for giving the opportunity to give the lecture on this anatomical depiction of left-sided lobectomies.
Thank you, Dr. Sarna. Yeah, great. So I think same questions to you that we had to Dr. Vijayaraj. First is, we know the anatomy on the left is different. He said multiple different approaches for right upper lobe, and I think you showed one or two different ways of doing the left upper lobe as well. So one question is fissure last versus fissure first. Do you have a preference of how you go about, or either which way is fine?
I think the thing for me is, especially on the left side, since we've shifted to anterolateral approach, it almost gives a VATS-like feeling. So I always believe that, it should be a mix of both. For me, the lower lobe is more of a fissure last, because you can finish the lobectomy in about 20-25 minutes if you're by VATS, and robot it takes definitely a longer 1 hour. But it's quite sequential. So you vein, then you go after the bronchus, and then you go after the artery. Even however thick the fissure is, you can manage. But the upper lobe, I think it's more of a mix. You have to do posterior, anterior, because for those who are starting off, upper lobe is going to be the one that they always will be scared of. So I insist that you should do the hilar release first. Once you do the hilar release, you exactly know, and you find the lingular vein. You exactly know where the fissure is. And we've actually found, although I couldn't show it in the short lecture, but there are windows within the lung which you can actually use to get onto the artery and to get onto the fissure, even if it is thick. And those are usually from the anterior aspect, both on the right side and the left side. So there are windows. Probably I can do it in some other time. But those windows can give a plane for development of the fissures. For the upper lobe, I would always suggest, do a mix of both. Don't just believe that you will do it in one way. Try to do anterior, posterior, superior, everything, and then go ahead with it. That's my suggestion.
The next question I think we have from the delegates is, one is, what is the dose of ICG you give? What is the route you give it through?
Okay, for lung resection particularly, I don't like to nebulize like Srijan you do before the procedure in esophagus. So the dose is usually 2.5 milligram uh, uh, per shot. So this is what I would suggest. And because the washout is so fast, you can actually within 15 to 20 minutes, you can actually have a complete washout and then reuse it for lung segmentation. So it's not like other parts of the body where, like in bowel or esophagus or other things, where that stain remains. In the lung, the washout is pretty fast because you have a large volume of blood circling through the lung. So in 15 minutes, you can actually reuse ICG. So I would suggest, if you're using it for segmentation, you use it like once in 15 minutes, 2.5 milligram per time when you want to find it. But if you want to use it for vascularity, like for example, after I now have started checking all of my stumps. I showed you, I don't know whether I showed you all the stumps and all anastomosis. I checked before and after just to make sure that small bronchial vessels are coming up to the edge of the stump. That is one I've started checking. The other one, like I showed you in the video, especially in lower lobe, when you're doing a lower lobe, many people think that you have problems with upper lobe. I've had more problems with lower lobe. I've stapled the left main bronchus thinking it's the lower lobe bronchus. I've stapled the lingular artery when I was stapling the interlobar pulmonary artery. So in the fissure, I think before you staple, use ICG for vascularity assessment also. Because when you have, a proximal takeoff of the segmental artery in both sides, there is a chance that you will occlude the lingular or the middle lobe artery when you apply your stapler. So in that time, I close the stapler, then I use ICG, make sure that the middle lobe on the right side or the upper or the lingula on the left side is having good perfusion, and then activate the stapler. So ICG, I use it in those situations. And obviously, inflation, deflation, use it in a lower lobectomy on both sides. I would insist, use the inflation, deflation test. The upper lobectomy usually, when you're doing an upper lobe, it's very difficult to occlude the left main bronchus or the lower lobe bronchus, etc. But when you're doing a lower lobe on both sides, it's very easy to do it. So inflation, deflation, especially when you're doing a lower lobectomy, is must. And for those using blockers, I think I mentioned before you staple a blocker, I have a checklist for bronchus transection. So before stapling the bronchus, we ask the anesthetist to pull out all the suction catheters which they have on the side. Any bronchial blocker, pull out the guide wire if you're using a ANT blocker. If you're using an easy blocker, sometimes the tip can come into the upper lobe ostium when you're stapling the upper lobe. So ask them to take the blocker out completely before you staple. That is one tip I would like to give.
Right. The next question is, I think I see is, if there is a tumor which is blocking the bronchus opening and the lung is not deflating, even despite lung isolation. Now I know you're on robotic and you will have capnothorax and you will create your space, but I think many of the VATS surgeons do find this specifically for carcinoids because you have a partially inflated lobe and it becomes bulky. You don't have capnothorax to flip the lung around. So how do we manage in such a situation?
Okay, so in VATS, my suggestion is, commit on the transection of the bronchus. That's the easiest way. So especially in carcinoids, when you go posteriorly on both sides, right as well as left, you can actually, that you're going to transect the bronchus at some point. So on the right side, I usually transect the bronchus intermedius, and immediately everything goes down. Okay, on the left side, so because the bronchus intermedius, you're going to transect anyway, whether you're doing a right lower lobe sleeve or a middle lobe sleeve, whatever. So do the distal transection first, and that will actually ease up the pressure. And in carcinoids, thankfully, on both sides, you can do the transection first itself. So I'm a big proponent of, in case of stuck and obstructed systems, I'm a big proponent of bronchus first surgery. So attack the bronchus first. We usually, like this lecture was actually for beginners who are entering. But as you get more and more complex cases, we have now turned to bronchus first approach for lobectomies. So do the bronchus first, especially the upper lobe, cut the bronchus, and then everything. These obstructive systems will get relieved, and everything will go down. So commit on the bronchus first if possible. But I see a challenge when you're doing uniportal, right? So the end-on view, sometimes it's challenging to do a bronchus first. Any
Correct.
tips you have?
No, I think I totally agree with you. Go to the bronchus specifically for bulky tumors, and once I would say cut it from the main bronchus first.
Yeah.
Whichever. I think cutting the bronchus is a great advice. I think the next question is about the post-op care. I think what is your system? Are you using passive drains? Are you using active suction drains? When do you pull the ICD out? Is it based on fluid outcome? Is it based on air leak? Is it based on both?
So what we do is, we've not gone the American way. We are not doing 23-hour lobectomy now. I'm still, I think our average removal of the ICD is on day 2. That is, I leave post-op day 2, I mean. So it's a third day from the date of surgery, if you ask me. So for us, we have the medulla with us, but unfortunately, we have only 2 of them. So the go-to is actually a standard ICD bag, not even a negative pressure drain. The reason for that is we test our lobectomy after we do it on table. So whatever problem you have on table, address it on table. Don't allow it to haunt you later. So after you test on table, it's very rare that you have to keep the ICD for more than post-op day 2. Now, if you had a lot of adhesions and you did a little bit of decortication, yeah, in those situations, we would start with the medulla in the beginning itself. A digital drain, I mean. We start with the beginning itself. If we have a regular ICD inside and on post-op day 1 or 2, patient develops a air leak, then we first shift them to a digital drain device. This is our policy now because our re-exploration rates for grade 3 and grade 4 have totally gone down by almost 80% after shifting to digital drain systems. We don't use the Synapy. We don't have it yet, but we just, for us, so most of the patients go home, go with the regular ICD, and we are more of not output based. If the lung is expanded on day 2, there's no air leak, we just pull it out. 300, 200 doesn't matter at all for us. On the other hand, if it's a digital drain, it usually goes up to 0 immediately. Within the 1 day, it goes up to 0. And then you can remove it on day 1 or day 2, depending on how it is. However, there is a word of caution when you have a large air leak, which is seen on the digital drain system. My advice, this is usually seen. So suppose you have a minimal air leak, you put a digital drain, and the next day when you come in, you see a large air leak, more than 300, 400. I usually don't wait. Day 3, I usually get in and manage it, because then you're looking at more than 10 days, 15 days with the ICD. That I don't allow. So this digital drain has allowed us to triage our post-op air leaks. So most of the patients usually go home by day 5, day 6, or day 7, based on this method.
Right. Perfect. I think the discussions can go on and on, but I think we'll conclude. We have answered all the questions put in here. Thank you, Dr. Saruna, Dr. Vijayaraj, and Dr. Sagar. I invite President-elect Dr. Chandramohan sir to kindly deliver his comments and then the vote of thanks from IASO. Over to you, sir.
So, good evening, all. Am I audible?
Yes, sir. Perfect.
Yeah, an excellent talk. And I was got a surprise call from Subbu when I was in a gym that I have to talk at the end. I was watching the program on my phone. Then I have to rush to my home, and then now I realized that I am not only guys trying. Sharavanan is in some shopping mall, and he's speaking from there. And I think mistaking him as some TV journalist, a gathering should have been around him, public watching him what he's doing. Anyway, excellent stuff. Thanks, Vijay, Sagar, Sharavanan. It was amazing. It is great to see that how the subspecialization in lung surgery is growing in our country, done by our generation. The youngsters who are more and more concentrating on subject are doing wonderful thing, and hats off you guys. And of course, I have to thank when I was watching the delegate list, I was shocked to see many big people like George and others are watching it, and it's a great thing that people are interested, and a lot of residents from all across the country are watching. I was just looking at it, and it is good that our program is getting popular, and even we could learn a lot of things from this tips and excellent videos, and it has enhanced my knowledge about lung cancer as well. So thanks to you guys, and of course thanks Subbu, Srijan, Seba for his fantastic thing. IASO is thankful to you guys, and let us hope we can have more programs in the future. Thank you very much. Bye-bye.
Thank you so much, sir. This brings us to the conclusion of the webinar today. Announcement about next month. The topic for next month is going to be gastric cancer. We'll have the IASO masterclass with its mock exam and the expert talk on 11th of August, Tuesday, 7 p.m., followed by Mastery of Surgery, where we'll discuss technical details like today on 25th of August, Tuesday, 7 p.m. With that, it's a wrap up from here. Good evening to everyone. May you have a great remaining of the day ahead. Thank you.